2 announcements. You're going to have a weekend quiz. I'll get it up this evening. I don't know what time. And then it'll be due sometime Monday evening. Because as soon as everybody is done with it, all of the answers and the questions will show up. So you'll be able to assess how you did. It only does that with at-home assignments. It doesn't do that with the other ones. Have you noticed, though, that if you're using a computer or a tablet, you can find the question, right? Yeah. And if you got it right, you can see the answer. But if you got it wrong, you're going to have to go look up the answer, which I think is just fine. You can't do that on your phone, though, can you? You can't find the question on your phone. But if you do you know that? Does everybody know that? You go to the grade book and then you view all content. Yeah. So if you you can access Top Hat on the internet as well on a computer or a tablet, and there you can see the questions even from the quizzes that we took in class. FYI. Okay. That quiz is going to be over the weekend. If you don't get it done by the time I say to get it done, you'll get a 0. Okay? So do that. And people do that all the damn time. I can't even understand. It's basically 3 points, and they just don't do it. And then here's another announcement that's important. Only for this first test, only for the first test, you're going to use Top Hat for 10 questions because I want to show you color histology images which you can blow up and stuff. Does that make sense? So I need you to bring your devices. On Tuesday, you'll just use it briefly, and then the rest of the test will be written in Scantron. Is that okay? Okay. All right. So, and then the other one, oh, I've got one other little thing I want to tell you. And that is this. Okay. So I just put something up here for you which wasn't there before. And that is check for tutoring and study groups times on the resources page. I got those up there. There are free tutoring in the STEM Center. Okay, that's Joe, one of the senior lab aides, who will also probably be teaching lab next semester. She's very, very bright and is really good at helping students through lecture and lab material, and that's free. She has to be there anyway. You might as well go see her if you need to. And then my lab aides, who are in the lab with you, as part of that class, they actually have to do a project. And some of them have chosen to lead study groups as their projects. So they will meet with students on Monday on one campus and on Friday on another campus. Never here, because nobody comes here but us. They just make me teach here because some people live downtown. And here's what they're going to do. They're going to try to help you guys put together study groups and lead the study groups. And if enough people are there, they'll be able to say, okay, you 5 are Melanie students. Yeah? So let's get you guys together, studying together for lecture and for lab, and they're going to lead you guys. And a lot of them have had me. And then you guys are Craig Caron's students, and they get you guys together. And then hopefully what will happen is you'll have the genesis of a study group, and then a resource that you always know is there if you need help with that study group. I am not a people person. I don't like studying in groups. However, it is very effective for anatomy and physiology. It's super duper effective if you can take the time to form a study group, especially with people who are as smart as you and work hard. So especially, I hate forming study groups with people who don't study. I'm literally doing all the damn work here, right? So just dump them, right? Just end it early. It's a bad relationship. Okay, so that's that. Everybody good? Okay. All right, so today we are going to briefly finish up the last little bit with, we were just talking about arthritis, right? Okay. And then we will get into muscles. The muscles that we do today are not on your first test, they're going to be on your second test. However, you are going to start doing them in lab on Monday, so this will be super helpful to you because lab is super overwhelming for that first week. I want to give you some confidence and some ways to know that this is something that you can do successfully. Okay, so last tidbit is we were talking chronic arthritis, right? Yeah. We already did acute, and we're going to do chronic. Okay, so with osteo. Yeah, osteoarthritis. So osteoarthritis is the wear and tear, yeah, arthritis. A lot of times associated with aging, but it doesn't have to be. Like if you damage a joint, I broke this finger, that one's got osteoarthritis. Carrying my freaking husband's speakers for the 7,000th time. Broke his finger, so you can see that it doesn't move and it's inflamed. So you get osteoarthritis because of damage or wear and tear, and we can see that in the early stages it's primarily inflammatory, but notice in the later stages you actually get thickening of the bone, which reduces mobility. Yeah? Does that make sense? And like I mentioned last time, There's a genetic predisposition. If you have less collagen in your cartilage, you're more likely to get it. So if you look around in your family and your grandpa and your aunts and 3 uncles and a cousin have arthritis, you got a predisposition, you might just sort of start expecting it. Not much they can do about it except to reduce the pain and inflammation. Go ahead.
I have a question about collagen.
Okay, go ahead.
People have started talking more, what's become a little bit more trendy is doing the peptide collagen powder, gel powder, or you can eat it, ingest it. Mm-hmm. So does that help at all?
Well, here's the deal. Well, I don't have the specific knowledge of whether it helps, but the biochemistry says that it shouldn't. Okay. Because here's what happens when you ingest proteins. You ingest a complex protein like collagen, or let's say you tried to ingest insulin because you were type 1 diabetic. What immediately happens in the stomach is you break it down to amino acids. It does not get absorbed as collagen. It gets absorbed as amino acids. So it's a really expensive amino acid supplement, is all it is. There's no reason on earth that it should get absorbed that way. Now, if you take a lipid-soluble supplement, it can get absorbed intact. But collagen's protein, so I have no idea why that could possibly work. Same thing with using collagen on the surface of your skin. You don't absorb it, right? So I know they can sell you any damn thing because nobody likes to be old or ugly, but it's going to happen to all of us. But battle it with things that actually work, right? Yeah. Some oils on the surface of your skin can actually help. If that works, I don't understand the biochemistry, and probably neither does anybody else. Okay? It's the reason that you can't take an insulin oral supplement, right? It's the same reason. Diabetics, why can't they take an insulin oral supplement? Because they're going to break it down to peptides or to amino acids in their gut. So, so I don't have that knowledge, but I have skepticism. I ain't buying it, let me just tell you. Even if it told me, you will look like you were 22 again, I'll be like, first of all, I think I would look better at 30. And second, no. Okay. Rheumatoid arthritis is next. And rheumatoid arthritis is more serious because rheumatoid arthritis is an autoimmune disease in which your immune system makes a mistake and starts attacking your synovial membranes. And remember synovial membranes right here? They make the fluid, right, that reduces the friction in the joint. Lose the fluid, increase the friction, cartilage damage, and then the bones rub against one another and you get bone spurs. And this is serious. So, rheumatoid arthritis, here we go. Rheumatoid arthritis tends to be progressive. It's autoimmune. There are no cures for any autoimmune disorders that we've ever found. Okay? And like all autoimmune diseases, they are more likely in women than in men. They are not associated necessarily with aging, although we tend to get autoimmune diseases more frequently in your 30s and 40s and later. Women are more likely to have it than men. It can get even more serious than that. Here is rheumatoid arthritis as well. It can completely degenerate and make the joints completely immobile. And it can be life and health threatening, for instance, if it happens in your vertebra and it causes rheumatoid arthritis that compresses the organs of your abdominal pelvic cavity. Then they can do surgery to straighten it up, but it doesn't actually cure it. It just straightens it up, okay? So this is autoimmune, and you just progressively lose your synovial membranes. There's a juvenile form of it that's a little rarer. There's rheumatoid arthritis, more common in women. There is, it doesn't seem to be related to either sex hormones or sex chromosomes, though. There is a good hypothesis that's being tested right now as to why women are more likely to get autoimmune diseases and why in their 30s and 40s. It's kind of an interesting hypothesis, and there's some decent evidence for it. First off, when women become pregnant, you have an alien creature in you, and you can launch an immune system response to that alien creature, especially during the childbirth process. We used to think that there was no mixing of fetal and maternal blood, but now we know that that's wrong. There is mixing of fetal and maternal blood. Part of what allows women to maintain a pregnancy is it actually depresses your immune system during that time. Now, then you have a baby, or you can even have a late-term miscarriage, as long as the baby has antigens on their cell surface. Then it gets into your body. The baby cells get into your body, and then sit around doing nothing until your immune system gets ramped up because of some kind of infection, right? And then it goes looking for foreign cells, and then it starts to destroy them wherever they are. Maybe they're in the synovial membrane, right? So how the hell did they find this? This is really interesting. It happened about 15 years ago when they found, so they had this woman that had a genetic disorder, not an autoimmune disorder, and they were doing blood tests, and they were doing DNA sequencing to figure out what was going on with her. And they kept finding sequences on the Y chromosome present in her blood, and we're like, what the hell's going on? So they looked to see if she had a chromosome disorder, because there are some women who have a single Y chromosome, right? She didn't have that. She had a Y chromosome that was identical to the Y chromosome of her 20-something-year-old son. Okay, so she actually had circulating cells from her childbirth in her body. Now, it wasn't that he was male that was a problem. That's just what made them be able to detect it. And then they're like, what the hell's going on? Oh, you get some of your kids' cells, and they're foreign to you in your body. And then if your immune system ramps up and starts looking for stuff, it can actually start finding it. So can you imagine why women in their 30s and 40s might be more likely than any other population group to get autoimmune diseases, right? And now they are testing that hypothesis by testing women in their 30s and 40s who have had pregnancies against a population that almost never does, the Catholic nun population, who volunteer all the time for studies like this. I mean, you can have had children and be a nun totally, but a lot of them haven't, right? And so they're testing it to see what the stats are, which is kind of interesting. But women get MS, women get lupus, women get this, they get everything more frequently than men. Okay, so what do you do about rheumatoid arthritis? Not a whole hell of a lot. You try to reduce the pain, reduce the inflammation. If surgery is necessary to be life or quality of life sustaining, you can do that, but it's not going to cure it. And then they go to the heavier anti-inflammatories like prednisone, like corticosteroids. But those are something you don't want to take if you could avoid it, because they have all kinds of side effects associated with them. And then the very last of the arthritis is called gout or gouty arthritis. And gout is a weird one. Here's the deal with gout. With gout, doesn't look very cozy, does it? With gout, what happens is all of us eat protein and nucleic acids in our diet. And there's byproduct from protein and nucleic acid in your diet. And they're nitrogenous wastes like uric acid and urea, okay? But most of us clear those really readily out of our bloodstream with our kidneys. Some people make too much of it or have trouble clearing it, or both. And then the uric acid concentration increases in your bloodstream, and it tends to deposit and crystallize in soft tissues. Put crystals in a joint and then wiggle it. And then that's what happens, right? Really, really painful, okay? So this one's chronic, but it's like intermittent. I know that sounds like an oxymoron, but it's like you get it, and then you change your diet, and you take some medications to clear out the uric acid, but then you get it again, right? So this is gout. This is gout. This is gout, okay? Pretty damn painful. Now, interestingly, historically speaking, especially men are more likely to get gout than women. And they used to call it the disease of kings because you get it primarily from eating high protein diets. And if you think back, who got the most protein? Oh, let's be honest here. Who got the most of everything? Men! you kill something and you come back, and who do you feed first? You feed yourself first. So, and then in addition, it was the disease of kings, not queens for that reason, but why kings? Because who historically had high protein diets? Rich people or poor people? Poor people in India, do they have high protein diets? No, they've got primarily rice as the staple of their diet. So this is the disease that tends to be associated with very high protein diets, in addition to a genetic predisposition, right? And also if a poor person had it, they probably wouldn't even say anything. They just go to work anyway, right? But the disease is like, oh, my lumbago, my gout. Okay. So women do get this, and of course, more in westernized societies than in other societies in which we have access to high protein diets, right? So in the United States, it's not so much as separate in the sexes. Okay, so that's gout. There's not really a cure, but you can change your diet and it will help with gout. It doesn't cure it though. Okay, so now what we are going to start, this stuff that I'm talking about right now is not on your test on Tuesday, okay? It's gonna be on your second test, okay? But it's directly related to the stuff that you guys are going to be doing in lab all next week. And it will help you a lot in lab if you will work with me and try to get the logic of it. So what we are going to do is muscles, and eventually we'll do muscle tissue. But chapter 9 was articulations, yeah? But now we're going to start talking about wiggling the articulations, which will have to do with the muscle activity, right? Chapter 10 is basically the organization of muscle tissue and how it causes contraction. And then chapter 11 is axial musculature, and chapter 12 is appendicular musculature. Eventually, by the time you guys get to test number 2, all of the muscles on your lab list will be on test number 2. But you'll have a lot of time before then. A lot of time to like absorb all of that kind of stuff. So what I want to do today is I want to teach you the physics and the logic of how muscles work so that you have less memorization, right? Because if you understand something, you don't have to memorize as much about it. Does that make sense? So that's what we're going to do today, and I'm going to make you flop around, I'm going to make you wiggle your body, I'm going to make you show me some body movements. So before we get started with that, let's talk briefly about how muscles work in general. First off, if you see the prefix MYO or the suffix MYS, it means muscle. So you're going to see it used quite often. So let's talk about the mechanics and the basic physics of how muscles work. How muscles work is that they have at least 2 attachment points, okay? And so let's talk about this. You guys all know where the deltoid is, right? Everybody know where the deltoid is. Okay, so the deltoid is here. Deltoid is here. And so it has attachment points. And when a muscle contracts, it has an attachment point that stays stationary during the contraction, or stationary-ish, right? And it has an attachment point that moves during the contraction. Just like I told you guys before that we use them as leverage for body movement, this is my stationary point of attachment. I'm going to use a tendon to try to pull on something else. That's the movable point of attachment. Okay, so terminology associated with this. The part that doesn't move when you contract is called the origin of the muscle, the fixed or immovable point of attachment. And the part that does move is called the insertion of the muscle, okay? So here's what you need to understand about muscles. Muscles only pull, they never push, okay? So this is important because if I'm doing this action, guys, right? I can think about where the muscle is attached, so stick with me. If muscles only pull and they never push, right? So tell me, it doesn't have to be exact, just tell me approximately where the origin has to be of a muscle that does this. It has to be what to the elbow?
Proximal.
Proximal to the elbow. It goes further than you expect it to for reasons we'll explain in just a second. And in order for you to do this, the insertion has to be distal to the elbow, right? That makes sense? So it's pulling, okay? Muscles only pull, they never push. Here's something that a mistake that students make all the time. In order to move a damn joint, so people tell me all the time, okay, the biceps brachii does this, and its origin is up here and its insertion is there. Well, that doesn't make a damn bit of sense. How the hell are you going to move it, right? You have to cross a joint to move the joint, right? And now let's talk about how you're going to get it to move the other way. So we just did this, but if muscles only pull, they never push, and you need to do this, what do I have to have in order to do that? I have to have a muscle on the other side of the joint. So I'm going to do this, and I want you guys to show me approximately where the origin is for the muscle that does that. Has to be on the back side. And where does the insertion have to be? On the back side of the forearm. Does that make sense? So they are arranged in opposing or antagonistic pairs, right? Okay, so if I have a movement that I'm talking about, the muscle that does that, we call it the agonist. And its buddy on the other side, we call it the antagonist. Yeah? And sometimes a muscle will have a helper. If it has a helper, you guys may or may not know this, the muscles that do this, there's actually 2. There's the biceps brachii, and then there's one deep to it called the brachialis. Okay? Biceps brachii and the brachialis. One of them is the agonist, and the other is the synergist. It's its helper. Right? That make sense? Okay, so let's practice with a different joint. I'm going to show you guys an action. I want you guys to try to tell me with your hands where the origin is for this action. You ready? Okay, so here's the action, not the opening but the closing. Where's the origin? Zygomatic arch. Zygomatic arch, yes, got it? Where's the insertion?
Mandible.
Mandible, yes, okay. So that's the prime mover, or the agonist, okay. Now I'm going to show you the opposite action, and now you guys try to tell me where the muscle must be that does that. Origin should be where? Approximately. Where's the origin have to be? You're just yanking stuff around, guys. Where's the origin have to be? Has to be down here somewhere, doesn't it? And then the insertion has to be there. So this is the agonist for that movement. Antagonist, okay? But it's got a helper. There is a muscle that helps this masseter right here, which is the agonist, which gives it more range of motion. It actually is up here and then inserts down there and increases the range of motion. That's called the temporalis. So agonist, antagonist, synergist. Yeah, the helper. How do you decide what the synergist is? Well, I probably have to tell you which one does most of the action. Or you can look at the huge one. That's usually the agonist. And then the little ones, like this one's really thin, is usually the synergist. Does that make sense? So sometimes there's more than one muscle that does an action. Everybody okay with that? Okay. So now what we are going to do is we're going to start practicing. We're going to learn body movements, which will correlate directly to the muscle action. So I don't know if you guys have looked ahead in your lab book, but the muscle part is like 50 pages long, right? It's got a ton in there. And there's a column for every single muscle that has the action. So you, without exception, have to know the action for every single muscle. But if you use this, you won't have to memorize all of them. You'll actually be able to work your way to most of them. So that's what we're going to work on today, okay? So body movements correlate directly to muscle actions. So we're going to start with what we call the angular movements. And the angular movements are movements that change the angles between two bones. But now we have to acknowledge what the angles are between two bones. What is the angle between my arm and my forearm? Approximately 180, right? Angle here is 180. This one's a little different, right down there, right? So we're going to look at two actions now. Flexion means something specific in anatomy. You can't use it the same way you use it at the gym. You don't flex every muscle, okay? So flexion means something different. In anatomy, flexion means going from anatomical position and decreasing the joint angle. Watch. Right? That's decreasing the joint angle to 90, less than 90, right? Okay. Flexion. This is also flexion, guys. Decreasing the joint angle. Yeah. This is flexion. Yeah. This is flexion. Okay. And this is flexion. That one doesn't actually move the other way, right? It's still decreasing the joint angle. Does that make sense to you? Okay, so with flexion, let's talk about it. I'm going to show you guys an animation. And with this animation, I want you to tell me where you think the origin and the insertion are for doing this action. You ready? Okay. I'm going to do the hard one first. Okay. This is flexion of the trunk or flexion of the abdomen. You'll be able to see the muscle fibers in just a second. Okay. Remember what an origin is and what an insertion is, and tell me where the origin is for that action. Where's the origin? What? If it was on the sternum, you would say that you were doing that.
Yeah.
And that's awkward for all of us, right? Where is the origin? Yeah, it's on the pubic symphysis actually, and the insertion is here. So with the sit-up, the origin stays still, right? And the insertion is here. Does that make sense? Okay, got it? Okay, so now that is called flexion of the abdomen. What about this one? Where's the origin and the insertion for this one? You're gonna have to be specific about the bones yet. Where's the origin? Origin is up here. And the insertion, cross the joint to move the joint. Okay, insertion is down here, right? Okay, so that is flexion at the elbow. Okay, so Where do you think you are generally going to find muscles responsible for flexion? Which surface of the joint? Anterior surface of the joint. So this is flexion, right? This is flexion of the hip, yeah? This is flexion of the neck. This is flexion of the elbow, right? There's one exception. There's one joint that flexes only posteriorly, and that's the knee, right? So that's the exception. You'll find knee flexors back there, right? But remember, our knees are weird because we started out quadrupeds and ended up bipeds, and everything's kind of weird, okay? So that is flexion. So generally, you're going to find a muscle responsible for flexion on the anterior surface of the joint. Now, you will use that to your advantage next week when you start studying the lab. Because when they start telling you that there are wrist flexors, where are you going to look for them? You're going to look for them here, not here. Yes? Okay? And when they tell you a muscle is responsible for flexion, you're going to look for it here unless it's the knee. Does that make sense? So there are muscles that are called flexors, and now you'll know where to look for them. Okay, now extension is the opposite. Okay, extension means something specific in anatomy. If this is flexion, extension is replacing it back to anatomical position, which is increasing the joint angle from where it was, right? Okay, not from anatomical position, but from where it was. So if this is flexion of the neck, this is extension of the neck, and this is flexion of the hip, this is extension, but sometimes you can hyperextend. If you go past anatomical position, right, more than 180, right? Flexion, extension, hyperextension. Knee, flexion, extension, hyperextension, only once, right? How about elbow? Flexion, extension, don't hyperextend your elbow, okay? Now, this one's a little counterintuitive because the plane doesn't continue going up, but at the shoulder, this is flexion, yeah? This is extension, and you can do hyperextension as well. That makes sense? That's flexion. Okay? That makes sense? Okay, so let's look at an extension. Okay. All right, so I want you to look at this one. Again, same question. Try to figure out where the origins and the insertions are. Okay? And then I'll have one more question for you guys about this one. Where are the origins? Yeah, down here, and the insertions are up here. As a matter of fact, that actually has serial origins and insertions. The lowest ones start and then go here, and then you got more that go here, right? That's why in yoga or Pilates, when they ask you to do this and they ask you to roll your vertebra all the way up, you can go, because those are the erector spinae muscles, and they've got serial origins and insertions, but the origins are lower, right, or more caudal than the insertions. Okay, one last question for you about this one, and that is this muscle is the antagonist to what muscle that we've already talked about? To the rectus abdominis that we just looked at, right? Is the antagonist to the rectus abdominis? Yeah? Okay, got it? Okay, so now I want you to look at this action, and I want you to look at the joint that's moving and then try to tell me what it's doing. What joint? Yeah, it is extension at the knee. Where are the origins? Way up here on the femur, and the insertions, you got to cross the joint to move the joint, so it has to go past the knee. Does that make sense? So that's extension of the knee, okay? People get really weirded out next week because you end up being really confused. Because if I have a joint, a muscle, and I do, I have some muscles that cross this joint on the anterior side and then cross this joint on the anterior side. Let's think about what that muscle could do, because otherwise it just looks like a hodgepodge of people lying to you. What can that muscle do at the hip? What can it do? Flex at the hip. But what can it do at the knee? Extend at the knee. Does that make sense? Okay. So when you look at it critically and you're like, okay, it's running down the anterior surface of these two different joints, what the hell could it possibly do? There's some logic to it, but when you first read it, you're like, you just told me it flexed. Why are you lying to me? Right? I told you it flexed one joint and it's going to go. Does that make sense to you guys?
Yeah.
Okay. So I want you to, when you start studying the muscle actions, look at them critically and start moving your body to figure out whether it makes sense. Because if it doesn't make sense, you're not going to remember it anyway, right? Okay, all right, so that is extension at the knee. All right, so now we will, generally you find muscles responsible for extension on what surface of the joint? Posterior, except for the knee. Yeah, the knee is weird, okay? So you will have a set of muscles right here that will be wrist flexors, and you will have wrist extenders on the other side, okay? Now that gets kind of hard because in the cadavers, of course, they don't preserve an anatomical position, right? Sometimes they're like this, and sometimes they're like this. So how the hell do you figure it out? Well, you follow from the palm up to this surface, right? And these would all be potential flexors, right? Or you follow from the dorsal surface up to the olecranon, and those would all be extensors, right? So regardless of how you change your body position, this is still the ventral surface, okay? They just don't preserve an anatomical position, so we didn't do it just to confuse you. Okay, abduction. Abduction is easy to remember if you just think about kidnapping for a second, because if you abduct, you take something away. Take it away from what? Usually a midline. It doesn't have to be the midline of the body, but let's start out saying that it's start in anatomical position, and you abduct at the shoulder, right? Take it away from midline. That's abduction, okay? Here is me abducting at the hip. Does that make sense? Okay, so abduction. So before we go any further, where do you think you're going to find a muscle responsible for abduction? What surface? Lateral surface of the joint, yes? Okay, lateral surface of the joint. Okay, now with that in mind, hands, forearms, these are the hardest muscles for me, okay? I have to study them every semester. I don't know why, they just don't stick very well. But if I have a muscle called an abductor pollicis, it is going to do that, right? Expect to find it on the lateral surface of the thumb so that it can do that, right? It wouldn't be called an adductor because that would have to be on this surface, right? So let me show you a couple different kinds of abduction. So this is abduction at the shoulder, yeah? Watch this. This is abduction at the wrist, okay? But I could use this midline and I could do abduction of all the fingers, right? So this is the midline that I'm talking about. You just have to be specific about what you are actually moving, right? So this is abduction of the whole wrist. This is abduction of the whole arm. I can't abduct here, right? Not possible. I can abduct here. Yeah? Okay. So this will be an abductor, not an adductor, because that doesn't make sense. So let's talk about abduction. So you can do it now. Classic abductor is the deltoid, right? Abducting at the glenohumeral or shoulder joint, okay? And I know that you know, but tell me anywhere. Tell me anyway. Touch the origins. Yeah, clavicle and scapula. The insertion, it's actually the deltoid tuberosity of the humerus, right? A lot of times those points that you guys are learning this week and next week don't seem to be related to anything. You will strap stuff to them during the next 2 weeks. So they'll start to be relevant again, okay? So that is abduction. Now, adduction is usually adding it back. You abduct it away, you add it back, okay? So this is abduction of the shoulder, this is adduction, yeah? So show me adduction at the wrist. Yeah, so you went from that way and you gotta go back, okay? This is abduction of the fingers, adduction. Yeah, back to that midline. Abduction at the hip, adduction. These muscles are called the adductors, not the abductors, because that wouldn't make sense. Yeah? Okay, so that is adduction. Generally, guys, you will find the muscle responsible for adduction on the what surface of the joint? Medial surface of the joint. Got it? Okay? Okay, and then last one before we move to the rotation movements, and this is called circumduction. This is actually just 4 movements in series, really, and you can only do it truly at ball and socket joints, but they call it something different when you do it at your neck. So circumduction is taking a ball and socket joint and moving the end of the limb in space in a cone, right? This is circumduction. So circumduction with the arm at the shoulder. This is circumduction at the hip. Okay, but it's really 4 movements, isn't it? It's really what? What's this? Flexion.
Abduction.
Abduction. Extension or hyperextension, and then adduction. So not surprisingly, in order to do circumduction, you need muscles on all four sides of the joint. Right? Okay, so that's circumduction. Okay, so now these two will see whether you've got it, right? Whether you're really getting the pushing and pull, or the pulling relationship. Okay, so I want you guys to do this because it doesn't look like very much when I do it, but you can feel it. Okay, I want you to start in an anatomical position with your shoulders, and I want you to move your shoulders. It's going to look when I do it like I'm moving my forearms, but I want you guys to feel it. What I want you to do is rotate your shoulders medially toward the center of your chest. It's called medial rotation. Okay, and now I want you to rotate your shoulders back out towards your back. That's called lateral rotation.
Pops my rib in and out.
Sorry, don't injure yourself. Yeah. You can just do one arm. Okay. Okay. So lateral and medial rotation is what those are doing. They're taking a bone and they're spinning it around its own axis in space. And now I want you to think for a second. In order to do medial rotation, where does the muscle have to be attached? Where should the origin of the muscle be?
If it's at the
medial rotation, origin.
Back here, so it should be on the post. Right.
You're doing medial. Everybody do medial rotation one more time. Start from here, rotate toward the front. So where is the origin? Yeah, the origin has to be on the anterior surface of the trunk. With me? Because it's pulling. Got it?
Okay.
Yeah? And then the insertion has to be on the limb. Yeah? And if you put it right here on the limb, you don't have much range of motion, but if you insert it further over on the limb, you have more range of motion. So does it make sense to you that one of the functions of the pectoralis major muscle is this? Another function of the pectoralis major is it helps with this, right? It's actually attached there. It can help with that as well. That makes sense? So medial rotation, okay? Anterior surface onto the joints. You can do it at your hip too, but it doesn't look like very much. So, because it doesn't have as much range of motion. So that's medial rotation at the hip, right? I'm taking the femur and I'm kind of twisting it in, right? And this is lateral rotation at the hip. But you can feel it more than you can actually see it on me. Go ahead.
So lateral rotation would be back here.
Yeah, that's the next question. So, where would the muscles be that are responsible for lateral rotation of the shoulder? Okay, origin where? Posterior surface of the trunk. Insertion where? Onto the limb, this. Do you know a muscle that's strapped that way, that goes here to here? When guys work out, girls hardly ever get it to get that shape, and you're like, oh yeah, what is that? Nope. Latissimus dorsi, lats, right? The lats can do, in addition, the lats can do this, but does it make sense to you that the lats can also help with adduction because of the way that they're strapped? Does that make sense? It depends on which fibers you use of the lats. So the lats, since they go here to here, they can do this, but they can also do this.
So that would help out with like the female back fat. Everything gets pushed together when you wear a bra.
It's true.
Yeah.
Yeah. Well, it doesn't do anything to the fat, but it will make it more toned under the fat. We've all got a six-pack. It's just like some of us have like a cooler on. That's all, right? I'm just like keeping them cold. That's all. Okay, so that's lateral and medial rotation. Got it? Okay. So sometimes you will have a muscle that does multiple things. Like, don't be surprised at all that the pectoralis muscle might be able to do this, but then also do this because of the way that it's strapped, right? So again, you want to logically be able to look at it, wiggle your body a little bit, and figure out how the hell it could do that, right? Because then it'll actually stick. Instead of rote memorization that you will lose instantaneously. What I would like for you guys, especially those of you who are going into PT, I want you to know what the damn muscles are supposed to do, right? Because I'm going to break something soon, and my husband's been in physical therapy a million times, especially because he broke his clavicle at Burning Man.
I can't believe that.
Oh my gosh, I'll show you guys a picture of it. So my husband decided to do a whiskey tricycle jump. He's 6'6". At Burning Man. It made a really good story, right? Yeah, and apparently it was a rickety tricycle. Yeah, it was like this high too. And it was like in 4 pieces. It's great. And he's like, that's an embarrassing story. I'm like, no, that's an amazing story. It's like, why do you tell stories about me? I'm like, well, you're not here to defend yourself. Okay, so other movements. Let's talk about other movements. Okay, this one is specific to these 2 bones. You ready? Okay, these are called supination and pronation. I don't think they, yeah, they didn't have a picture of it. Ready? Okay, start with your, this time we're not going to move this, we're not going to move the shoulder. We're going to move this joint right here. And what we are going to do is we're going to take the radius and the ulna and we're going to change their orientation of one another. When you're in anatomical position, tell me the radius and the ulna's relationship to one another. They are what? Parallel. Okay, and now I am going to cross them over one another. Yeah? And I'm really, it looks like I'm moving a wrist, but I'm really just moving my elbow joint. Does that make sense? So I'm moving, the muscle that's moving is actually right here, okay? So which movement does what? If you end up being able to drink soup, you just supinated. If you end up pulling it out, you just pronated. Supinate, pronate. Supinate, pronate. Does that make sense? So you will not surprisingly find a muscle right here called a supinator muscle.
Is that the same muscle that you can just do it while your hands down?
I didn't know people could do that. It's like, what is happening?
Yeah, mine can do it without moving my hand.
What the hell is happening?
But my wrist, I can just move.
I'm not quite sure that you're... I actually don't know what muscle's doing that because I've never seen that action before. So you got a supinator and then you're going to have a pronator teres. So if you sit there and think about it, like sit and think about it for a second. If I did this, where would the muscle be on the joint? Should be over here, right? Because I'm actually pulling from here. But if I did this, where should the muscle be? Can you imagine? Like I'm pulling this direction, right? Does that make sense? So I've got a supinator and a pronator, right? It's like, does that make sense? So the supinator and the pronator are kind of hard muscles to figure out what they do, but I want you to like practice supination and pronation and then look at the muscles and go, okay, I can see how that muscle would do that, right? In addition, please get into the habit when you start getting comfortable with the cadavers next week or the week after, whenever you do, instead of just pointing at a muscle and going, that's the supinator. Follow the supinator from its origin to its insertion. Follow it the whole way, because then you'll be able to imagine what would happen if you yanked on it, right? And then you start to actually understand instead of memorize. Okay, so that's supination and pronation, and then let's do foot movements. I usually stand on a table to do this, but look at this table. Does that look like a good idea? No, it does not. I will die. Go ahead.
So only the radius and the ulnar that does this?
Yes, it's a specific movement to the radius and the ulnar. Okay, now we're going to do ankle movements. And you're just going to have to try to see, because I usually stand on the thing, but I can't. Okay, with the ankle, nobody could decide whether it was flexing one way or flexing the other, so they called both of them flexion. But it's named for what it flexes toward. If you flex toward the dorsal surface, it's called dorsiflexion. If you flex toward the plantar surface, it's called plantar flexion. Does that make sense? Okay, so dorsiflexion would be like when you're stretching your calves. That makes sense? Stretching your calves, that's dorsiflexion. So everybody dorsiflex, make sure you can feel it, okay? Before we go any further, where is the muscle going to be that's responsible for dorsiflexion? Where?
Up on the shin.
Yeah, it's going to be on the anterior surface, yeah? And it has to go past the ankle, right, to pull there. That makes sense? Okay. Huh?
I'm feeling the light there.
Yeah, there's a muscle right there that's called the tibialis anterior. If I had to guess, I'd say, well, that one probably does dorsiflexion, right? That makes sense? What? Yes, you get shin splints. Shin splints are actually the muscle sort of yanking on the connective tissue of the bone a little too much. Okay, so plantar flexion does this, like standing on your toes. Okay, tell me where the muscle is going to be responsible for plantar flexion. Posterior surface origin up here, right? Insertion down here. The further the insertion goes, the more range of motion you have. So you actually have more range of motion that way than you do the other way. Okay, so let's look at it. Here is plantar flexion. Find the origin and the insertion for me. Do you see? Yeah? And they didn't show all the way down to the insertion. The insertion actually goes all the way sort of to the bottom right down there, but they didn't left his skin on for the rest of it. Okay, now, this one is also hard to see, but it's not hard to feel. Okay, so in order to walk on uneven surfaces, in addition to doing dorsiflexion and plantar flexion, you also have to be able to move your ankles this direction, right? So you have to be able to do eversion, which is taking the sole and pointing it laterally. So do that for yourself. It's not a huge movement, okay? And inversion, which is taking the sole and pointing it medially. Where is the muscle going to be that's responsible for eversion? Lateral surface, right? And the muscle that's responsible for inversion? Medial surface. Does that make sense? Kind of like abduction and adduction, but it's got a special name down there. Okay? You guys all right? Okay. And then jaw movements, although some of them are not unique to the jaw. Let's do the last two first. Elevation and depression. So I already showed you elevation and depression of the jaw. Here's elevation, depression. Okay? So in order to elevate a bone, you're probably going to be on what side of it? Top side. In order to depress a bone, you're going to be on the bottom side. So elevation and depression of the scapula. Elevation, depression. Elevation, depression. Where would a muscle be that was responsible for elevating the scapula? Here, there, right onto the scapula. There's even a muscle called the levator scapulae. Wonder what it does. Okay, and then there's muscles that can depress the scapula, right? That good? Okay, elevation and depression. And then protraction and retraction. Protraction and retraction are hard to understand in a lot of joints, but they're easy to understand here. Protraction is taking two bones, the maxilla and the mandible, keeping them about the same orientation, angle to one another. If you protract, you end up going like this, sliding it forward. You end up with an underbite. And if you retract, you go pull it back. I've already got an overbite, so I can't make it look more overbite. So, overbite. So protraction, retraction. Those four movements are actually involved in chewing, because when you chew, you don't just go, right? You protract, retract, you even move to the side. I need to teach you the name of that one. Okay, protraction, retraction. These movements, these jaw movements, allow us to have almost an unlimited food resource because we've got hinged jaws, right? So could a mammal with hinged jaws eat a freaking elephant if they were patient enough? Yeah, if you can catch one, take down an elephant. Don't eat elephants. Elephants are amazing.
I know.
Go ahead.
I just have a question.
Okay.
Personally, I had a really bad underbite as a kid, so I had 10 years of braces where they had
10 years, you poor soul.
Yeah, it was a long time. But my question is, they had to I had to wear rubber bands to pull my jaw back. Is that retraining the muscles?
It is retraining the muscles and the tendons and ligaments, because when you actually make it so that the tendons and ligaments don't need much stretch, they eventually shorten, and then the muscles actually get stronger one direction than the other. So you can retrain the muscles. And then the last movement is opposition. And opposition is special to us and some other primates and some other critters. Opposition is taking the thumb, or hallux, and being able to make contact with all of the digits. Opposable thumbs, we have opposition. This, in combination with this, and the surface area of our cerebral cortex is the reason we have global warming. Dolphins would probably do a better job, but they didn't have opposable thumbs. Right? I mean, honestly, we might want to let them try at this point. Really, we're like, dude, go ahead. So this is opposition, right? Okay, that's opposition. We are not the only ones with opposable thumbs, but we are the only ones with that trifecta, with hinged jaws, opposable thumbs, and a tremendous area of our cerebral cortex, which can be left for anxiety and creating combustible engines, and I don't know, fighting on Facebook, whatever the hell you want to do with it. Okay, so let me tell you a preview of things to come, and I am going to stop in just a second, but stop wiggling. Okay? Okay. Don't get used to getting getting out early. As soon as those other guys get caught up, I'm going to keep you the whole damn time. Okay, so next week, you guys are going to start on articular muscles and lat, and they're hard, and there's a lot of them. Okay, so I just taught you some of the mechanics to help you understand the actions. But before you understand the actions, you're actually going to do the naming. So the deal is that there are conventions that muscles use for naming. If I were you, I would read through this before I go to lab, so then the flexor carpi ulnaris would be able to tell me something. Oh, it's a flexor, right? And it's a carpi, and it's not on the radial side, it's on the ulnar side. It's telling you. Or the rectus abdominis is telling you the fibers are going straight up and down. Or the levator scapulae, or the adductor pollicis longus. So read through how they are named so that when you start looking at them, it's not like, ah. It's like, I think I know what that's named. Okay? And then we'll do that on Thursday to make sure you guys have all got it. Okay. I'll post the quiz sometime tonight. Do not email me about it before 9 o'clock because that's still tonight. And then you'll have until Monday to do it. And remember that you need to bring your device on Tuesday. Okay? Hi.
Hey, I have a question. I've been trying to get on your website this past week, and it keeps saying that I'm denied, but I've been in it before with no problem.
What it probably is there was a bot that was trying to spam my website.
Oh.
So everyone with a username that ended in 4 digits got kicked out.
That's probably why.
So I need you to change your username and re-register.
Okay, I tried to do that,
and then you have to change it to not 4 digits. It can't have 4 digits in it.
Okay.
Because the bot was always using 4 digits, so we went through and cleaned them all out, but we didn't have way. Okay, so, and then what I want you to do is change it on there, and then also send me an email and say, this is my username, this is the email that I'm using. I will go in and manually approve it.
Perfect,
okay?
thank you.
Yeah.
Oh, I couldn't get into Top Hat until question 5.
Okay, stay there.
Okay.
Okay.
I have this too, but Top Hat kept kicking me out at the beginning of the class.